Well, Doug, thank you very much for making time again
Yeah,
to join us. We got loads and loads and loads of questions. So really, this is just an opportunity to catch up again and just try and whiz through some of these and just make sure that everybody got what they wanted to out of the session.
sure.
Now, one of the things that comes up loads is I'm already doing sublingual immunotherapy for my dust mite. I'm already on an egg ladder, on a milk ladder. Can I also do OIT? I always try to reassure my patients that actually it's quite possible to just do all of this stuff and find space to do it all alongside each other. Nothing else has to stop. But do you say the same things to your patients?
Yeah, completely agree. In fact, if they're doing sublingual immunotherapy to environmentals, whether it's dust mites or pollens, that's good. Typically that's just going to help. If they're doing any other kind of ladders or something, all of that just goes in and absolutely do it together.
Yeah, great. Now, I often spend time speaking to my patients about that they often ask about the data, about the performance of these programs, and we keep a really close eye. And I know you do as well, just so that we can benchmark and make sure that other centres are sort of performing with the same sort of level of severe reactions, that we're keeping them to a minimum, that we're not getting any more than anyone else is, that we're getting as few dropouts as anyone else is. Overall, we reckon we get 95% of kids through their program. But I often find myself talking to the patients about the 5%. Why did they not get through? Our experience is it's probably about half of them, it's just logistics. It just proved too difficult for them to come to the visits every couple of weeks, fit it into their daily life. That's fair enough. I mean, that happens. But there's also medical reasons why people don't complete. And one of them, which somebody was asking about, is that even the first dose, the really tiny doses that we sometimes start people on, even that was causing a reaction. What are your options for those patients? Do you just say, sorry, that's it? Or do you talk to them about Xolair? Do you talk to them about sublingual? Where do you go with that?
Yeah, that's a great question, and I rarely would tell somebody that's it, because there's usually always another option. And sometimes what we'll do is we'll do extra dilutions. If they want to stick with OIT, we can dilute it down even further because, as you know, there's published thresholds by which people will react, and their threshold may be lower than maybe what's published. What I found is even just doing an extra dilution or two and starting them lower and going slower, we can still build through and have success. Alternatively, to your point, if they're at the right age and things work out, slit is an option. Xolair is an option for where it's available. So I've found any one of those usually work out pretty well. The other thing too is if they are reacting at that low of a dose, we do widen our thinking and look like, are we missing something? Is there something else underlying that's predisposing to that reaction?
Yeah, no, that makes a lot of sense. I know you introduced me to the low and slow concept, which of course is a mantra that all OIT specialists now live by,
Yeah.
and it does seem to bypass most issues. I mean, going back a few
Mm.
years, I mean, the other thing people are understandably asking about is this risk of eosinophilic esophagitis,
Yes.
and certainly, our initial experiences were if first sign of trouble, that's it, just stop. Whereas actually, I think we've all got a bit braver now, haven't we, over time? And I think this acknowledgement that if you do stop, it gets better. In a way, just gives you permission, doesn't it, to sort of say, well, actually, let's see if we can just find a way around this. Are you doing the same?
Yes, and in fact, I kind of started that years and years ago. Was one of the first to treat patients with eosinophilic esophagitis or EOE with OIT because you've got different mechanisms in play. And again, not everyone will have success with it, but probably a vast majority of the time, well over 80% of the time, even if they have EOE, we're able to find a workaround to still get them to be able to tolerate the life-threatening foods.
Yeah, it's just there's this little bit of a tendency, isn't there, to, or maybe this is a British and less an American thing, to sort of focus on the downsides and lose sight of the fact that there's a reason we wanted to do OIT in the first place, and if we give up because there was a problem, you're missing out on those benefits. And actually, the benefits are so long term that you really have to do everything you can to make sure that you don't lose that opportunity.
Yeah, that's a really good point, and I have kind of a similar mindset of let's focus on what we can do, and I always liken OIT to flying. So before any kind of dose, you do some pre-checks, just like anytime an airplane takes off, they do pre-flight checks. So we'll do pre-dose checks, and the pilots and the crew and everyone's checking the weather, and they're checking their radars, and they're seeing what the forecast is going to be between there and the destination. And usually you can predict pretty well and navigate that. But sometimes unexpected weather comes up in flight and you have to just adjust the altitude, or maybe you have to fly around a storm or something. And it's very similar with OIT, is sometimes things come up that are unexpected, but it doesn't mean we put on a parachute and bail out of the plane. It means we just need to perhaps adjust our altitude or our speed, or navigate a slightly different route, but ultimately we can still get there.
It's a great analogy. Yeah, very good. And you mentioned about being good at predicting. How good do you think we are at predicting? Because people often say to me, in fact, one of the most common questions I get from patients on their first visit is my child too allergic to do OIT? And they're not thinking the way that I might be thinking of that, which is, just to let you know, my child's had 5 rounds of epi and 3 visits to ITU and the sort of things that scare the life out of us. What they really mean is the size of the skin test was really big. Now, the way I normally would explain that is saying, look, it's not a particularly reliable predictor. If you've got 2 kids that are otherwise identical and one's got a much bigger skin test, will one have a bumpier ride than the other? Well, chances are maybe, but that's it. I mean, do you think I'm understating that? Do you think there's more that we can get from the testing, or we just really don't know?
Now, I think this is one instance where size doesn't matter.
Yeah.
So it's like, no. So that size doesn't necessarily predict how we do it. And I've actually tracked this. We've treated close to 5,000 patients, and we've tracked this over time. And I've broken it down into their test results versus outcomes, and I don't have a difference, in terms of how our patients do. I think the greatest predictor of success is, that adherence, making sure that we have underlying issues well controlled, whether it's underlying eczema, asthma, anxiety.
Yeah.
Anxiety is probably the biggest underlying issue that we need to control and help our patients with. And then probably the thing that gives me the biggest grief is when people will get, say, unexpected viruses, because that's the one thing that we can't predict really well is, as you know, if somebody has an exposure, that immune system may get activated a few days before symptoms show up. And that little window is the one that I've found the most problematic, because people may have a reaction and they feel well, and then I'll say, let's see how they are in 2 days. And so many times, bam, now they have, a viral infection. And that's probably the one that we can't account for the most.
Yeah. I've always found it gives you real insight into human nature, the way
Does.
that people associate cause and effect, and that pretty much anything that happens on an OIT course, the parents will, in the first instance, however disconnected it is, they'll always put it down to the OIT. Whether it's a cough and a wheeze 12 hours later, or runny
Right.
stools, well, it's always OIT until we've proven otherwise. And it does take a lot of time and reassurance. I absolutely get where they're coming from. They're putting their child, they perceive they're putting their child in harm's way. That takes a lot of convincing to sort of say, no, let's just, hold tight. Stop, let's wait a few days, and you're right, almost always it will turn out to be a virus. It's just what kids do. Yeah.
Yeah, and that's a really good point. And we actually bring this up proactively with parents, even on some of their first visits. Of once you start the program, you're going to think every symptom your child has from now on is due to OIT, but that's not the case. We
Yeah.
always have to remain objective and look at everything that's going to happen and say, is this due to it or not? Or is this something else? And can we correct for something else? And them just kind of knowing that out of the gates, hopefully lowers the anxiety and gives them a little perspective that let's really watch this and see. Because like you said, something happening 12, 14 hours after, not going to be due to OIT.
Yeah, we spent a lot of time as a team chatting about what the ideal OIT setup looks like. And one of my colleagues is quite fixated with mindset and saying that he thinks that one of the biggest influences on outcomes is going to be spending time, ideally with the help of a psychologist, really getting people into the right place to
Yeah.
manage this for those, exactly as you've alluded to, those inevitable hiccups that happen,
Hmm.
because how you deal with them is sometimes going to be the difference between just dropping out and saying we just can't do this, and actually just being able to get back on that horse and just carry on and progressing really effectively. Yeah, I think on our side, I mean, our psychology services in the UK are just so sparse, unfortunately, and we're just not able to give our patients the support that we would like to. But the outcomes clearly get better, whether it's just managing food allergy generally or OIT,
Sure.
when you get the whole multidisciplinary support around patients.
Yeah.
So, Doug, one last thing I wanted to mention, it actually is the thing that came up the most, is, and it's something I think picked up by a lot of the guys on the UK side, is this difference between bite protection and food freedom. Now, I absolutely get that food freedom obviously just sounds inherently better than bite protection. Of course it does. If you say to
Mhm.
somebody, what would you rather, eat this freely, or just do this really sort of much less ambitious, but stay a bit frightened, but just a bit less frightened than you were type approach. And I do my best to just explain that more fully and people to understand. And I think certainly most of my patients, their real agenda when you push them is to just know their kids are safe rather than eating more freely.
Yeah.
And correct me if I'm wrong, but I think that there might be just a historical difference in the way this started. We talked about this before. Simply that OIT in the US was more about less worry, and I think this might simply be because it's covered by insurance, and in the UK it's not, so people are paying out of pocket. That there was less of an aversion to having more visits over a longer period and getting up to a higher dose, because why not? And I get that, but it would be really helpful just for your description of what food freedom really looks like. Are you are you really, as a patient who's been through this, just eating it completely freely, not worrying about maintenance doses, or is it a little bit more prescriptive than that?
Well, it's kind of a journey because if somebody, let's say they want to free eat, of course we have our protocol and the regimen that they need to do, and early on they need to be really strict with that. Once they finish the program and they're out, of the program, we call it graduated, for several months to a year or two, we monitor, we track. So we look at labs, we look at how they've done in the program, what symptoms have they had, and are they incorporating this into their diet freely. Initially, they are taking daily doses, along with being able to eat whatever they want. So it is a food freedom, and where they can eat whatever they want, whenever they want. They do again have to take that daily medication, or we think of it as a medication, their daily
Yeah.
dose. But as time goes on, what we found is we're able to trim that back to we used to talk we used to do a lot of what we call sustained unresponsiveness challenges. And I've actually evolved my practice over time, and I'm going to get to how I've evolved it. Actually was inspired by your group with the LEAP study. And but what'll happen is, once patients were taking their daily dose, they were freely eating, they were doing all the things, we gave it a certain amount of time. We had a certain number of parameters that we looked at where we said, are you ready for a sustained unresponsiveness challenge? And what that means is they go off their dose for a month completely, and they don't have any. And then we do a challenge in clinic to see can they tolerate it after being off a month. And a number of patients passed and did really well, and we were able to achieve that sustained unresponsiveness with those patients, or tolerance induction, however you want to say it. What we did find though is patients, there were a number of them that were hesitant to go off the dose.
Yeah.
That scared them. And so we evolved over time to where, well, let's just take a day away. Let's take 2 days away. Let's take 3 days away. And we got them to a point where all, tests were negative or had plateaued, and we had decreased their dosing frequency so much that it was just 1 to 2 times a week.
Yeah.
And the thing that's interesting is when we were doing the sustained unresponsiveness, We'd take them off for a month. We'd do the challenge. If they pass the challenge, we would still say, keep this in your diet 1 to 2 times a week.
Yeah.
Well, you can achieve the same thing by just gradually reducing the doses over time without having to go off for the full month if they don't want to. And my mindset became, well, that's what we do with early introduction of foods in patients, to try and get that in, is once they've passed and we get that early introduction of foods based on the LEAP study, once you get that in, well, guess what? You're recommending they take it 1 to 2 times a week. Why? Because you want to prevent. And so we actually shift our mindset from treatment in time to they have, whether you call it induction of tolerance, whether you call it sustained responsiveness or remission, whatever term you want to use, you put them in that state. But now we're dosing to prevent a relapse. Not necessarily treatment, is to prevent relapse. And it's 1 to 2 times a week, very similar to what we do with an early introduction of foods. Does that make sense? I don't
Yeah, it
know.
makes a lot of sense, and I completely
Yeah.
understand why that makes it would be better than asking patients who often feel that what they've achieved is extremely hard won, having
Yeah.
gone through that whole process, and then say, well, stop it, and you'll probably be okay in a month, but you might not be, in which case they
Right.
immediately envisage they're going to have to go through the whole thing again, and they've lost all
Right.
the gain. That's
Yes.
a big ask. Yeah,
It really is. And what was fascinating is when people started, everyone would say, can we achieve sustained unresponsiveness? Can we do it? Can we do it? But then when they actually get there and it's like, well, this is what you're going to have to do. They're like, hold on, I don't know if I want to do that. And I don't blame them. And so that's where we kind of evolved into just this transition because at the end, we're recommending the same thing. At the
yeah,
end, we're still going, whether you go off a month and you do a full sustained unresponsiveness or you just gradually ease into it, at the end of the day, we're still recommending you take this 1 to 2 times a week to prevent a recurrence. And so it's like, why not do that and ease their mind?
yeah.
And I've found a vast majority of the patients like that better. And it's nicer for them. It's easier for them. I think it's safe. It's just a nice gradual process. But then it truly does still give them full freedom.
Yeah.
Yeah.
Brilliant. Lovely. Doug, thank you so much. You're a legend. You're very good at this. Thank you. Really, really insightful.